Welcome to this version of Ethics Rounds, September 13, 2024. And you see the CMN code on the screen. If you have any problems trying to understand how to get credit, just send me an email and we'll fix that up for you. I'd like to begin that these ethics rounds are brought by the Ethical Advisory Committee of the hospital. I'd like to say that we offer consultations 24/7. How to contact us, the easiest way is to do it by Tiger Connect, and you could either search for UMMC Ethics or search for my name, Henry Silverman, or if all else fails, you could always call me on my cell phone number. This slide shows that this presentation is CME accredited, and again, the code is 2344A. I have something here to remind me to turn on the recording. The recording is on, so it reminds me to tell you that this presentation is being recorded and will be on the hospital intranet for on-demand viewing. So the objectives of this presentation is that upon completion of these activities, participants should be able to discuss ethical dilemmas in clinical practice and use an ethical framework for solving ethical dilemmas. So today, we're going to talk about the many different phases of futility, and more specifically, medical futility. The definition of futility is a futile intervention is one that will not accomplish its intended goal. And I have two scenarios from historic times. On the left, we see Cepheus in the underworld. What happened here is that he made the Hades, the god of the underworld, quite angry, and he was submitted to pushing up this rock up the hill. And once he got the rock up the hill, Hades would throw the rock down to the bottom of the hill, and this would go on in perpetuity. And so Cepheus could never obtain his goal of getting the boulder up the top of the mountain. On the right-hand side, we see the daughters of Danaus. What happened here is the daughters of the king Danaus, the daughters went out with men that Danaus did not approve, and Danaus got very angry and submitted his daughters to filling up this basin, which was futile because there were holes on the bottom of the basin. So that's the general concept of futility. Now, regarding medical futility refers to interventions that are unlikely to produce any significant benefit for the patient, either in terms of cure, prolonging life, or improving quality of life. So now we have two different aspects of medical futility. On the left-hand side, we have quantitative futility. That means when an intervention will have marginal or no physiologic effect, as opposed to qualitative futility, which means that a treatment might technically work, but will not achieve the patient's goals or values. So again, we have quantitative futility, or otherwise known as medical futility, and qualitative futility, which regards patients' goals. So, all right, I forgot to tell you the ground rules. The ground rules here is that all polls are anonymous. And I like to run an interactive presentation. And the third rule is try to mute yourself if you're not talking. Okay, thank you. So the issue of futility, one of the controversial aspects of medical futility is a controversial aspects of futility is essentially who decides on whether there's a futile intervention. So we have the whole concept is that there should be shared decision making between the physician and the family. And That's ideal. However, CPR, the whole issue of CPR has had somewhat of a checkered history. It began about 20, 30 years ago when physicians made patients DNR without informing the family. And when families found out about this, they got very angry. And so the pendulum shifted towards the families, and families believe that they have this unfettered right to ask for or demand for CPR in all cases. However, now the pendulum is somewhat shifting the other way towards that in some cases, physicians may have the authority to declare medical futility. Now, with this background, we have Maryland law, which has a law regarding medical futility. They instead of calling it medical futility, they use the term medically ineffective treatment. So it's and Maryland is one of only few states in the country that has such a law. Maryland law says as follows: a physician need not provide treatment that the physician believes to be medically ineffective or ethically inappropriate. The law further defines medically ineffective as treatment that to a reasonable degree of medical certainty, a reasonable degree, not absolute certainty, will neither prevent or reduce the deterioration of the health of an individual, nor prevent the impending death of an individual. So what does that mean? Essentially, well, if we take the second phrase, prevent the impending death of an individual. So if you have a patient with advanced metastatic cancer, and you feel that when a patient has a cardiopulmonary arrest, CPR is not going to prevent the impending death of an individual. So that's how one could claim that CPR might be medically ineffective. In regards to the previous phase, prevent or reduce the deterioration of the health of an individual. So let's say, again, you have someone with advanced metastatic cancer or advanced multiple organ failure, and now the kidneys are deteriorating. So now dialysis might be able to do its job in dialyzing the kidneys. However, the concept is that the patient will die even with dialysis. So essentially, dialysis will neither prevent or reduce the deterioration of the health of an individual. So, question. Does Maryland law's definition of futility align with quantitative or qualitative futility? So let me poll in front of your screen. So why don't you take a few seconds to, do you think Maryland law is more akin to quantitative futility or qualitative futility, or neither? Yeah. Okay, well, let me end the poll here. And here are the results. And we see that 25% said quantitative, 75% said qualitative. What do you think of those results? So actually, I maintain that the Maryland law is more quantitative rather than qualitative, and I say that because we're talking about medical effect of a treatment. A treatment will either won't prevent impending death or won't reduce the deterioration of the health of an individual. Essentially, it has nothing to do with qualitative futility. So sometimes I would get a consult and I'm asked that We think this treatment for this patient is medically futile because the patient will never wake up. And I asked, well, do you think that patient is going to die soon? And the answer is no. And I said, well, that's qualitative futility, and the law only deals with medical futility or quantitative futility. Okay, good, great. So the other question is when approaching patients and families to inform them with the determination of medical futility, how would you initiate the conversation? And this is what the rest of the uh, presentation will discuss by discussing cases. Also, Maryland law requires certification of two physicians to determine whether a treatment is medically futile, and the attending physician must inform the patient or the patient's agent or surrogate. The patient's surrogate, if they disagree, may request transfer to another hospital, and pending transfer, providers must comply with the request for treatment. If failure to comply would result in the death of the patient. So those are some of the other moving parts of the definition. So let's go over case one. Patient is a 78-year-old female with a history of supraglottic mass who required an awake tracheostomy. Surgery was consulted for a peg placement. Mass was determined to be cancerous. There was a meeting with the patient and the family, and both the patient and the family decided on inpatient chemotherapy and radiation treatment. And the patient underwent her first radiation treatment and tolerated it well. However, the story goes on. In early June, the patient would frequently remove her trach mass, require an Ativan to treat the agitation and the use of mitts. One day, she actually self-decannulated her trach, causing her oxygen saturation to drop to the 70s. The trach was replaced, improving her saturation. According to oncology, the patient is not receiving the full dose of chemotherapy due to her poor performance status, and hence chemotherapy is thought not to be curative. Also, the radiation sessions were often terminated due to the patient being uncooperative, and hence the benefit of such treatments are questionable. Family meeting occurred in mid-June to discuss goals of care. Palliative care explained that chemotherapy hadn't started due to her poor performance status and her consistent refusal of treatment. Due to delirium concerns, patient remains significantly cognitively impaired, unable to understand her hospitalization or medical issues. Hospice was brought up. Her family decided against hospice care and chose to continue with active treatment. However, again, the patient continued to remove her trach mass, decannulate herself, and again, radiation sessions are often terminated due to the patient being uncooperative and actually saying, pointing, no more. I don't want any more of this. So the question is, are further chemotherapy and radiation treatments considered futile under Maryland law? So let me give you the other, let me see if I could get to this poll. Okay, let me stop the poll, share the results. It's 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 close. 46% said yes and 38% said no. Any thoughts you might have about this? You could all unmute yourself and say your thoughts or put them in the chat box. What do you think? Why? If you said no, tell me why you said no.
Dr. Silverman, this is Justin. I think that I think it's reasonable to consider, I don't think it's unreasonable to discuss offering the treatment, but it's clear that she's not able to tolerate it. And also, it sounded like you had implied that she was might not want it. And so I think if she was able to tolerate it, then the treatment would not be futile if she was able to at least tolerate it or she chose to have it. But the fact that she is not able to tolerate it due to her anxiety and issues, and it also sounds like choosing not to have it, then I think it's certainly reasonable not to go forward with treatment, but not that the healthcare team shouldn't at least offer it. Because if I felt like
Okay.
because if I felt like an intervention was completely futile, I would not offer
Okay. All right. Yeah, this scenario is a little bit different. Chemotherapy um, was not was thought not to be of much benefit. The radiation treatment could be, but um, so on one hand, the treatment itself might offer some benefit, but taking the whole situation in hand, um, it, it 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 seems like the whole concept of um, of the treatment being beneficial might be considered futile. Somewhat on a gray line, but we had a family meeting, and oncology informed the family that a cancer treatment is not curative and that the radiation treatments will have minimal effect. And therefore, the medical team has decided to stop her cancer treatment and radiation sessions as their irregular administration will have little or no beneficial effect. Also, the medical team told the family that an DNR order will be entered on the basis of medical futility. Um, and the family asked the medical team. Now, this family consisted of two cousins and an aunt, no other family members. And the family asked the medical team whether they were being told that chemotherapy, radiation, and CPR were not being offered, or were they being asked for agreement? So, how would you respond to that? Um, you could unmute your mic or put something in the chat box. How would you respond to that? The family saying, "Are you actually telling us that, or um, uh, uh, are you asking us to agree?" What do you think?
So I think they're being told, right? I mean, the physicians are essentially saying this is medically futile, and so as such, this is not something that we have to provide. And so um, they're telling them we are going to pull this. Now, CPR, I guess that could still be, um, but I think for the treatment itself, it's they're being told that this is going to happen.
Um, okay, other thoughts? I do agree that the gist of the um, conversation was that they were being told that no more treatments would be given. Oncology made a specific point about that, and they were also being told that um, a DNR order would be placed, but the family was surprised. Family members are not used to being told that treatments will end, and they wanted to know the distinction. So what happened was that uh, to somewhat soften the impending controversy here. It was explained to the family that the purpose of the meeting was to discuss options, and the aim was to achieve consensus. However, if consensus could not be achieved, then the family could exercise their right to transfer the patient. So what happened was the family expressed understanding of the conversation and requested 48 hours before deciding if they would like to have a transfer or pursue hospice care. And this was said in a very cordial way. And in the meantime, routine patient care continued, but chemotherapy and radiation therapy were stopped. A week later, the family came back in and they decided they wanted to discuss hospice options. And on a week later, the patient was transferred to hospice. Any remaining thoughts about this case? The family was up until that family meeting was insistent on the patient receiving radiation therapy and chemotherapy, and the medical staff was feeling quite uncomfortable with the patient continuing to refuse and having to be sedated for the radiation treatments, and it was all very uncomfortable. And the and I guess in one sense, by somewhat taking, for the lack of a better word, a firm stand against further treatment. I think, well, it appears the family got the message, and they realized that it was impossible to keep on giving the patient the treatments. All right, well, let's go to this next case. Patient is a 57-year-old female admitted for acute hypoxic respiratory failure in the setting of a right hepatic hydrothorax. Patient has history of hypertension, diabetes, end-stage renal disease on hemodialysis, peripheral vascular disease, protein C deficiency, a history of a DVT and a PE receiving warfarin, history of a CVA and a recent STEMI. Hospitalization was complicated by cardiac arrest, stage 4 sacral decube encephalopathy, cerebral CVA, and a concern for persistent infection. Presently, the patient is non-responsive and no acute distress, and she received the PEG tube. A week later, two physicians certified that CPR would be medically futile, and so they noted that in the chart. However, they in the family meeting, which consisted of the daughter, mother, and cousins, the daughter is designated as the POA. They were explained that the best case scenario would be likely for the patient to return to her current state, but this was not likely given all that the patient had already been through. And the recommendation was to change to DNI status if another arrest were to occur. Again, this was being recommended. The daughter struggles with what decision to make if she wants to make sure she hasn't missed anything. She plans to speak with the rest of the family this evening and hopes to have a decision in the coming days. 1 week later, the daughter continued to understand the concept of the code status, and she appeared to want to choose DNI, and she acknowledged the understanding of the importance of this decision. However, she is worried that if a decision was made without full family involvement, there would be family conflict. She reported needing to discuss further with the whole family about it. Um, a family meeting was set up for the end of April. The attending was asked how she would approach the family regarding DNR order, considering that the CPR was futile. In other words, would she tell the family that we're making the patient DNR, um, 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 eh, or just recommend? And she said she would merely recommend DNR due to concerns with mistrust that would develop between the medical team and the family if she told them that there were no plans for CPR. So they had the meeting, and at the meeting, the daughter was asked about DNR, and she remained undecided. Well, another family meeting occurred in the beginning of May. This time there was another attending. Um, and the meeting occurred with the daughter, the patient's mother, nephew, and brother-in-law. This new attending discussed concerns with signs of recurrent infection with onset of low-grade fevers, worsening picture of sacral decubitus wound, and limited IV access. There was no sign of neurologic improvement 3 months from the arrest, and the attending brought up code status and told the family, specifically the daughter, that the team decided to change the code status to DNR on the basis of medical futility. Okay, so how do you think the daughter responded to this information? Um, Feel free to unmute your mic or put something in the chat box. How do you think the daughter would respond to that?
I think she still just remained undecided. She doesn't want the response. It sounds like she doesn't want the responsibility of making the decision and the fallout from it, which I think we all can understand. And up until this point, I mean, the mom has been bad and is getting worse. I mean, unless she physically sees that, her mom kind of deteriorating in her hands, I don't think she's going to make this decision.
Okay, well, she wasn't being asked to decide. She was being essentially told that DNR was going to be entered. It wasn't being recommended. Okay, we got something in the chat box. And I think Debbie said, I think she would be relieved that the decision was coming from someone else. And someone else said, I second both. Both? Michael? Yeah. Are you agreeing with both options?
Well,
Maybe.
I'm just saying that I agree that she was probably so undecided and didn't want to make the decision herself, that when the medical team made the decision for her, it was a relief that she didn't have to be involved in telling her family that this was her decision to make the patient DNR.
Okay, all right, good. And Michelle was talking about lack of continuity of care. Well,
I,
um,
I think she was upset. I mean, so far it had been kind of this team discussion, and now all of a sudden the new attending comes in and says, "Oh, sorry, we're changing this. She's DNR, DNI," and I think she would have been upset.
um, okay, well that's a good point about the every week you get a different attending, you get a different approach. Well, during the meeting, essentially she felt relief. She actually said, um, when you said that you're entering a DNR, I felt relieved. And she said she was really hesitant about making such a decision. She said she did not want to make this decision. And the rest of the family in the meeting room thought the patient had suffered enough. Family was agreeable to pursue hospice care, and the attending said the focus would be on comfort versus any more escalation of care. 1 week later, the patient developed massive lower GI bleed. She was treated with morphine and midazolam to ensure comfort, and she died several hours later. So this was, if I could, oh, I'm going backwards here. We don't want to do that. Oh, you don't want to repeat this. So, um, I, 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 I'm of the mindset, if I could share my thoughts, is that uh, more families than we actually think don't want to make this decision because they feel that they would be the causal agent of death. And in this particular case, the daughter uh, kept on giving hints that she thought that DNR would be good, but she didn't know, she didn't want to upset the family. And so essentially, you could say that the medical team did her a favor, took the decision out of her hands, and uh, everyone was agreeing to that decision. One point I like to make is that in how to handle these medical futility situation is that it's hard to predict how patients how family members would react, but um, and but you're not going to know until you put it out there, uh, and if you put it out there in a compassionate way and make alterations based on how the family would react. So, all right, good. Another case to demonstrate the many different scenarios of medical futility. Patient is a 35-year-old female admitted with she had end-stage renal disease, receiving peritoneal dialysis, history of mitral stenosis with RV failure. She was transferred to UMMC. On arrival, she went into a PEA arrest and underwent cannulation for VA ECMO. This was in January. Fast forward to June. Attending met with the patient family and discussed that an interventional cardiac catheterization procedure, which was a procedure of last resort to fix her mitral valve uh, or fix her mitral valve leak, and they were told that the procedure um, couldn't be done in her patient. In the patient would not tolerate it, and essentially saying it was medically futile. Um, and so that was reluctantly accepted. And at another family meeting, the patient said, "I'm at peace and I want to go home." And she pointed to the sky. So people meant that she was ready to meet God. By the way, the patient was intermittently on Trach-collar, had full capacity, and engaged in conversation. The mother explains she wants to take her daughter home and express her plan not to withdraw treatment when they arrived home because it was discussed that once the patient would go home, that she would not be put back on the ventilation. And the mother said that she wanted to continue with intermittent ventilatory support and dialysis. However, it was explained that it would be very challenging to go home, given all the support that the patient would require at home. And the mother said, "Nothing is impossible to God." At a later family meeting, to discuss the feasibility of going home and the wishes of the patient. The attending said that the plan was to change her code status to DNR on the basis of medical futility. Um, and the mother said she was not in agreement with changing the code status to DNR. It should be the patient's decision. And she looked straight at us and said, "You're looking at a lawsuit." So, how would you respond to, to this statement? Instead of going to the poll, what are your thoughts? I mean, here we're getting pushback. And
Risk management, call risk management.
call risk management. Okay. All right. Other thoughts? The patient and the medical team are in agreement. This isn't mom's decision. That's a good point to bring up. There was this uh I don't know what word to use. This uh not strange, but this uh uneasy relationship between um the mother and the daughter. The daughter want did um um, would say she wouldn't want treatment. However, she did not want to get her mother upset. This was this um, 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 unusual. I shouldn't say unusual, but that that what was the relationship. She didn't want to die with the knowledge that she was upsetting her mother. Okay. And so um, and so um, so the the mother actually um, in terms of when the mom said about the lawsuit, um, I was the one who mentioned about DNR, and she said you're looking at a lawsuit, and I said nothing. Um, I I I I knew um, when the ground was shaking, or maybe I was shaking. Um, f Further along in the conversation, it was explained that the CPR would cause harm without benefit, and that is why CPR would not be performed. And the mother agreed that if the healthcare team felt that CPR would not be helpful at the time and would only cause harm, then the team should not do it. Otherwise, her expectation is CPR will be done. And the attending explained that the decision not to pursue CPR would be made if and when the patient deteriorated and it was thought that CPR would cause harm and suffering. So it was somewhat of a middle ground approach. The mom voiced her objection, and we um, uh, deliberated for a middle of the road situation. The patient continued to be a full code. A week later, the patient and mother, however, agreed to a DNR DNI. Patient is on a tray collar, but however, when she experienced respiratory distress, she asked to be put back on the ventilator, even though she was DNI, and she would intermittently receive fluids and pressors for hypotension. It was soon explained to the patient and the mother that due to the amount of treatment she was requiring, it would be impossible to go home. Patient said she cannot live this way. However, she doesn't want to die. So to be continued. Let me ask one last question about this case. I said that the patient would intermittently receive fluids and pressors for hypotension. So what do you think? Are the fluids and pressors for hypertension medically futile as per Maryland law? Um, uh, you don't have to go to the um, well, maybe, well, what do you think? You could put that in the chat box, either yes or no. Or not futile. Okay, no, no, no. Give me your thoughts about that. Why do you say no?
I mean, she's able to ask for them, and so they're keeping her alive to continue to participate in her life and her care. So, I mean, for her, that might be enough.
Um, Meaning enough that uh, it, it's acceptable for
Yeah,
her to keep on living.
yeah,
Yeah.
exactly,
Yeah,
exactly.
right, right. Uh, another vote. Oh, yes, qualitative. Now I'm talking about MD law. MD law is quantitative. So I appreciate your responses. I go back and forth, but I mainly wind up saying no as well. On one hand, you could say eventually she's going to die. So one could say that presses and fluids are not going to reduce the deterioration of her health. However, it's um, however, I I think there's a time frame. One could say that me eating a meal is medically futile because eventually I don't like to say this, but eventually I'm going to die, even if I keep on eating. However, I like to think I have another 20 years, okay? And so I think I don't know how much longer this patient is going to live. So I think this concept of deterioration of the health of the individual has to be bounded by some time point. And so I do agree that it's not considered medically futile as per NP law. So thank you for those thoughts. So let me go with this last case, um, and then we'll wrap up with some uh, epiphany. Maybe. 52-year-old male, history of hypertension, presented to the ED, worsening symptoms over 6 days, including fatigue, shortness of breath, abdominal discomfort, and reduced oral intake. On admission, he had a PE, bilateral pleural effusion, and ascites. Further tests revealed metastatic, poorly differentiated adenocarcinoma at the GE junction. At a family meeting, the patient and the wife expressed a strong desire for aggressive treatment. They have a 4-year-old child, and both the patient and the wife who have a strong faith, which plays a central role in their decision-making process. Our patient is originally from Cameroon, and many of his family members are still there. Oncology said that chemotherapy would not be offered because of the advanced stage of his cancer. Patient spouse, there was mention made about the patient going home, but uh, this was determined to be too difficult, and the patient hence requested to initiate hospice in the hospital. A DNR order was placed in the chart on the basis of medical futility, to which the patient agreed. Um, and now the patient also appointed his brother to be his POA, not his wife, but his brother. His brother is a minister who is living in Scotland. Okay. So now, the social worker received a voicemail from the patient's brother stating that he will be arriving in the U.S. tomorrow, and he also demanded that the code status be reversed to full code and that only he should be asked if there were decisions to be made. In other words, no other family member should be involved. The patient suffered respiratory distress and had to be intubated with worsening mentation. So how would you respond to the request to reverse the code status? either open up your mic or put in the chat box. I think you all are getting used to writing in the chat box and talking. What do you think? CPR is medically futile. Originally, the patient agreed. He made his brother the POA. Okay, it's a coachable thing with African men, meaning that it's the men who decides and not the women. He was made the POA. Uh, the patient was intubated after the brother reversed the code status. Um, and, and that was the issue. So this was a very different situation from the previous cases in more ways than one. And let me see one other. Okay, computer issue with Zoom. Okay, you could put in the chat. Um, right, so uh, right, the patient wanted to be DNR, but he gave decision-making
Yeah,
authority.
virtual. This is a ethic
Yes.
lecture.
Okay, you're testing out your mic, the patient. Yes, right. But the brother said no, and and this was again you could say a cultural thing as well. And so on one hand, now you could say the brother uh, uh, may his I mean the patient may his brother the POA and the um, the authority of healthcare agents, appointed healthcare agent should be to follow the previous stated wishes of the patient. Um, uh, and but when the brother reversed uh, the DNR, the patient was still awake and he wasn't objecting to that. So very strange situation. So a meeting was held with the brother, spouse, and other family members who were in Cameroon. It was then a, a, a family um, Manash, maybe you could mute yourself. And they were all on the brother's cell phone. And the family kept on asking, how is it possible for a young person who had been so healthy suddenly be diagnosed with metastatic cancer? All the family members requested that all care be continued, and if his heart were to stop, the doctors should revive him. So this was a very uh, difficult situation.
Dog.
Uh,
She was here today.
Minaj, could you mute yourself? Okay. You're
I'm
breaking
just
one of
saying
the
that you will
rules.
continue more suspicious.
Okay. I guess maybe you don't.
Correct, correct.
So, this, uh, so
In the report, I saw it today.
would anyone tell the brother that we have to make him DNR?
I know our scenario is different, but radiologist may be overread.
Okay, I muted Minaj, so we won't be hearing from him anymore. Um, so let me continue on. This was a difficult situation. So follow up, the patient was finally extubated a few days later, but remained unresponsive. And a few days later, while receiving a dilaudid infusion, the patient continuously moaned and his abdomen became tense and tender. And a recommendation was made to increase the dilaudid infusion, acknowledging that respiratory depression might occur as a foreseeable but unintended consequence, which means that you keep on giving the diluted infusion because the intention was to relieve the suffering. This is the principle of double effect. That evening, the patient's brother, spouse, and other family members visited and requested a change in code status, the DNR, and increased the pain medication, but denied comfort measures only, and which means that um, there's always a gray area between um, comfort between hospice care and or comfort measures only and continuation with all other interventions like fluids, TPN, um, blah blah blah. So patient passed away peacefully the following day, and so remaining thoughts about this journey through CPR, medically futile treatments. Um, Let me just end by saying there's as witnessed by these four cases, there's a continuing of a degree of difficulty when the healthcare providers decide to forego medically futile interventions. On the less difficult side, we have case two, where the daughter felt relieved that someone else was making a DNR decision for her, which I think probably would happen more often than what we think if we decide to tell family patients we're making patients DNR. Then we have case one, where the family wanted to pursue aggressive therapy. They were told about no more chemotherapy, radiation, and patient would be DNR. Family exhibited it, if you want to call it, some pushback, but after thinking about it, they agreed with hospice and DNR. Then we have case three, where the mother threatened with a lawsuit, but for whatever reason did decide, and with the patient, for DNR. Very, very um, unusual, or I shouldn't say unusual, but different relationship with the daughter. And the concept there was that one may say that you're telling the daughter and the mother that the patient will be DNR, but depending on the reaction, you have to be ready to reverse course. And in case four, most difficult situation due to patient had sudden illness, cultural issues, and for, and the patient, the DNR was reversed, but eventually, and let me say this last thing, I think a lot of patients, a lot of family members will come to the conclusion of DNR when they see the gravity of the situation. And again, the last thing I would maybe it won't be the last thing I would say, that again, CPR, DNR holds a um, a, 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 a special or a different viewpoint compared to other interventions, like chemotherapy, radiation therapy. Surgeons are always, not always saying, but would say that we're not doing the operation because if the patient won't tolerate it. Um, so on one hand, if an intervention like chemotherapy, radiation therapy is not going to work, that should be raised in a family meeting. And then we have the issue of DNR, CPR, and I think that I we have a Maryland law about it, and I think we should use it. However, we should approach with sensitivity, provide clear information, support families, and recognize the importance of cultural sensitivity in healthcare. So I want to thank you for your thoughts. Any remaining thoughts from anyone? I I I thought this was a good discussion, and for the oh Michelle raised a good point about best interests or substituted decision making. Um, uh, so let me say this, as I said before, family members or um, designated agents, they have an obligation according to Maryland law to make decisions on the previous substituted decisions of the patient or in the best interest of the patient. And hence, the medical team could object, could disqualify a surrogate, or I should say, are not legally required to listen to a decision that they think is not in the best interest of the patient or goes against a patient's previous wishes. So in that last case, um, um, what help me out here? What in the heat of the moment would one tell the brother and the family members in Cameroon that we're keeping the patient DNR? That's when you're in the middle of the bull ring, what would you actually do? I think that I I think the best thing, I don't know if it's the best thing, but one should keep the door open for future conversations. As it turned out, in that case, the patient was extubated, put on pain medications, and was obvious to everyone, including the family, that the patient was suffering. Um, right. Well, actually, when the patient was still conscious and competent, he was not. He was not going against his brother. He and again, I think this is a coachable thing as well. He appointed his brother to be his POA, and if his brother said no, keep the CPR, he was agreeing with that. So the patient was changing his mind. And oh, does it apply to pediatrics? Good question. Um, and let me say two things about that. The short answer is yes. The longer answer is that in pediatrics, I am told by my colleagues in pediatrics, it is very because of the age of the infant, the child, and the lack of evidence, at least not as much evidence as in the adult world, that it's very difficult to determine when you have a futile situation in pediatrics, um, and also the pediatric world is much different from the adult world in terms of you know there's you have a new family with a new baby, and it just it's good question. It's more complicated. So the short answer, the law does apply to pediatrics, but because of all the different circumstances, it's hard to declare that. Good question. Thank you, Michelle. Any other final thoughts? Okay, well, I appreciate your thoughts. I'll I'll have this recording, um, and I'll have the chat. I think a lot of your thoughts in the chat box was good. You have your names in the chat box. if you don't want your chats to be revealed, let me know. Or I'll tell you what, I'll just keep it on my personal files. Thank you very much. Let me stop sharing. And I'm surprised you guys um are still here with me. Okay. All right, guys. You have a great weekend. Thank you very much. Okay. Bye now.
Thank you. Bye-bye.